Welcome, everybody. This is the topic of treatment, or the topic of discussion today. And this slide, I was asked to put some potential conflicts of interest, one of which is I was an advisory board member at Sanofi Pharmaceutical Companies, and I'm the chief medical officer of a company called Insulin Algorithms, which computerizes the principles of adjusting insulin doses. Today we're going to talk about a lot of things: the pathophysiology of type 2 diabetes, the targets, the medications, a description of the protocols that we use at MLK Outpatient Center, when and how to use insulin, and some outcomes, very brief outcomes of using these protocols. That's a lot of information. I've arranged for the slides to be on this Charles Drew University website, and I'll give you an address on that on my last slide. All the slides are in the packet. Oh, they're coming. Okay. They're in the birth process. All right. So here's a cartoon that's been used many times to describe what happens when we develop diabetes. Here we have the fasting glucose. The diagnosis is made here, and the first thing that is elevated is, of course, the postprandial glucose, but over time there's an obvious increase in the fasting glucose. Down at the bottom, we have what happens metabolically. And note that here's the diagnosis, and this is insulin resistance. So insulin resistance is, of course, part and parcel of type 2 diabetes, and it doesn't change all that much. It's mostly genetically driven, as well as obesity and aging. Note that the insulin levels in the blood actually go up initially, but then obviously decrease. And beta cell function, though, decreases. So how can beta cell function be decreasing when insulin levels are going up? Well, the reason is that the relationship between insulin levels and insulin sensitivity is denoted by a hyperbolic relationship. So people here who are very insulin sensitive don't need much insulin to stay on this curve, and this curve is the normal curve. They don't get diabetes. And as people get more and more insulin resistant, they need more and more insulin in order to keep them on the curve. And if you multiply insulin levels times the insulin sensitivity, that gives us something called disposition index, and that is really beta cell function. That is, the beta cell is functioning in relation to the amount of insulin sensitivity. Now, if you cannot keep up with that demand and the insulin levels then become less than they should be, you, quote, fall off the curve, unquote, and type 2 diabetes develops. Now, obviously, the two ways to treat this disease then is to either increase insulin levels or insulin secretion, or to make the patient more insulin sensitive. This is a very key slide. This is what happens over time. Here is the diagnosis of diabetes, and note that beta cell function is already decreased by 50%. And over time, it continues to decrease, and of course, that's the reason why we can treat type 2 diabetes anyway easily in the beginning with one pill, then we require 2 pills, sometimes 3 or 4 pills, and eventually insulin, because beta cell function continues to decrease. And unfortunately, there is very little we can do to stop that process, at least at the present time. Here we have beta cell function over time. Note we start again at 50%. This is treatment with diet alone, and you can see it decreasing. If you give a sulfonylurea agent, you get an initial increase, but the slope of this decrease is the same as the slope here. And finally, with metformin, this is metformin. Let's see, metformin is in the red, but I can barely make it out. You can see there's also a decrease. So that is the potential problem of type 2 diabetes, is insulin secretion keeps falling. This, of course, is a key slide. This relates the A1Cs, and just so we're all on the same page, A1Cs, as you know, is a test that reflects the average glucose for the past 3 or 4 months. This is the relationship between A1Cs and the relative risk of getting the microvascular complications of diabetes. This is from the immortal, so to speak, DCCT trial, which was published in 1993. And so diabetic retinopathy, which is the leading cause of blindness, nephropathy, over 50% of our patients who go on dialysis are there because of diabetes, neuropathy leading to ulcers, which are the responsibility for the 8 to 10-fold increase of lower extremity amputations, and microalbuminuria, which is the early sign of renal disease. All of these go up as the A1C goes up. But if you can keep it below 7%, there's very little risk of these microvascular complications. Once you get over 8%, it really takes off. And note that between 7 and 8%, there is some increase, but it's relatively small. And I'm going to come back to this area here as we go on further. Now, recently, it's been suggested that everybody should not have an A1C target of less than 7%. There are a number of factors that might allow us to relax that target. They are listed here: short life expectancy, long disease duration, the frail elderly, severe comorbidities, advanced complications. Once you start getting complications, you can't reverse them very easily by glycemic control. And then there are the social and educational issues, cognitive dysfunction, etc., and of course the patient's personal preferences. And people have talked about different target levels in these situations. At MLK, we use a rather simple delineation here. If we don't have very many of these, our target is less than 7, and if we do, then we aim for a target of less than 8. And sort of ironically, less than 8% is the Los Angeles County target for everybody. Now, there's a lot of pills we can use, a lot of medications we can use to treat diabetes. There's 12 of them. The ones on this slide that are underlined are the ones that LA County formulary has: metformin, sulfonylurea agents, glycides, which are rapid-acting sulfonylurea, so to speak, alpha-glucosidase inhibitors, TZDs. Welchol is a bile acid binder, DPP-4 inhibitors, GLP-1 agonists, something called pramlintide, a dopaminergic agent, and the newest drug, which I think is going to be an extremely important one, SGLT2 inhibitors, and of course there's insulin. So I'm going to quickly march through these and talk to you about various characteristics of these agents. Metformin we all know about. It's recommended as the first-line drug. The advantage is, of course, it's no hypoglycemia, there's no weight gain, and it's generically available. Of course, there are disadvantages. We all know about the GI side effects. You can't increase the doses rapidly because of the GI side effects. Now, the contraindications now really have changed in recent years. All of us know about the creatinine supposedly being over 1.5 or 1.4, and we shouldn't use it. The reason is that metformin is excreted entirely by the kidneys. However, the serum creatinine is a poor measure, really, of kidney function, and nowadays we use the estimated GFR, glomerular filtration rate. And the latest consensus is that if the eGFR is above 45, you can use it just as you would if it's completely normal. If it's between 30 and 45, you should only use, the max dose should be 1/2 of the usual max dose, and if the eGFR is under 30, you should not probably be using it. Hepatic dysfunction, this is a common mistake. People think that it can cause hepatic disease. It cannot. The reason that it's there is the thought that maybe lactic acid, which is of course the elephant in the room with metformin, because of lactic acidosis, that the liver may not be able to clear the lactate, but the liver has tremendous capacity to do it, and so that's usually not very much of a problem. There's a lot of evidence recently that metformin may very well not be associated with lactic acidosis, but it's ensconced in the literature, and therefore we all have to take that into consideration. Our old friends, the sulfonylurea agents, they work rapidly, except for weight gain and hypoglycemia. They have very little side effects, and of course they're generically available. Glycides they bind to the same receptor that the sulfonylureas do. They cause insulin secretion. They work very rapidly, and the insulin secretion stops more rapidly. And the disadvantage, of course, besides hypoglycemia and weight gain, is they have to be taken 3 times a day before each meal. Now, alpha-glucosidase inhibitors, when we eat carbohydrates, they're broken down in the GI tract and they're absorbed as glucose. And the enzymes that do that are inhibited by these medications, and therefore you get a flattening of the postprandial curve when you use them. There's no hypoglycemia and weight gain, which is advantageous, but flatulence is very common as the carbohydrate doesn't get absorbed and gets into the into the lower GI tract. The bacteria there act on it and cause gas and flatulence. We don't use it too much in this country. In China, it's used. In Germany, it's very common to be used. You got to titrate it slowly, and it's got to be taken 3 times a day. TZDs, a lot of advantages. There's no hypoglycemia. They increase insulin sensitivity. They're one of the only drugs that do that. You can take them once a day. Patients in renal insufficiency can use them, and that's a big advantage. There are a number of disadvantages. First of all, they don't work rapidly. It takes about a month to see any effect whatsoever, almost any effect whatsoever. You get a pretty good effect at 2 months, but a much better effect at 3 and 4 months. They cause weight gain, they cause fluid retention, and some patients are actually precipitated into heart failure. They have an effect on the bone, causing decreased bone mineral density and increased fractures, and they were very expensive. Now they are generic. The last one is a very popular one on television, but it turns out not to be true. There was a 5-year Kaiser study that suggested there was an association between lactose and bladder cancer. They have recently published, they haven't published it yet, but they have recently written, and it's going to be published soon, a 10-year study which showed that that association is not true. So although the courts are still dealing with these cases, it's probably not a problem. This is the well call is the binder, and it does lower LDL cholesterol, but it can raise triglycerides and has GI side effects, and it's not used very frequently. Now we got to talk about the newest classes of drugs, the incretin axis, and a little bit more pathophysiology. Down here at the bottom we have glucose, and here we're eating a meal, and this curve is the normal glucose levels, and of course this is the diabetic level. Note, as you would all know, that insulin secretion is markedly impaired in severe type 2 diabetes compared to normal. But note that glucagon is a substance from the alpha cell of the pancreas. It causes liver to break down glycogen to glucose, and therefore, instead of being able to store glucose when you give glucagon, actually the liver releases it. And you can see that normally when you eat a carbohydrate, glucagon is suppressed. But in diabetic patients, it is not suppressed. And so the defects, of course, are diffuse insulin release. Glucagon is not suppressed, which all causes hyperglycemia. Now, if you give insulin, the best treatment in a way, it does not affect the glucagon. Here is a situation where patients are eating. This is just the insulin levels, and the glucagon, as you can see, is not suppressed. And here we are actually giving insulin. Whoops, that's got to go backwards. We're actually giving insulin before the meal, and you can see that glucagon still stays unsuppressed. So what is the incretin effect? Here is a oral glucose tolerance test given, and you can see the glucose rise, and here's something called C-peptide, which is a manifestation of insulin secretion. And now these investigators gave intravenous glucose in such a way that they could mimic the glucose in the blood, the glucose concentrations, and yet you can see the insulin secretion, barely see it anyway, that's down here. So if you give intravenous glucose, you don't get as much insulin secretion even though you're getting the same glucose levels in the blood, and that difference is called the incretin effect. And this is very important because there are two substances that cause that incretin effect, one of which is called glucagon-like peptide number 1, GLP-1, and the second one is called GIP, and they are secreted after we eat. And they cause an increase in insulin secretion. They will suppress glucagon secretion, And by doing that, they decrease hepatic glucose production. They also delay the gastric emptying so that instead of having a rapid rise of glucose after we eat, there's a more flattened rise. And finally, and importantly, there is a center in the brain called the satiety center, which causes us to stop eating, and they will increase that satiety center so that our appetite goes down. And that's the physiology. Now here is the other part of the physiology. When we eat, these two substances are secreted, and they have their action that I just talked about. But there's an enzyme called dipeptidyl peptidase number 4, which inactivates them, and they do it very rapidly. The half-life of GLP-1 is only 2 minutes, and the inactive metabolites, of course, are inactive. Now, there is a class of drugs called the DPP-4 inhibitors. So they inhibit that enzyme so that after we eat, the GLP-1 stays up for a lot longer period of time. The advantage of it is that there's no hypoglycemia when you use it, and it can be given orally. That's the advantage compared to having to inject another one of those class of drugs. And the disadvantage is that you don't lose weight on it, and it's very expensive, and so far it's not available in the county. Now, the first incretin actually has a very interesting history. There is a lizard, a Gila monster, mostly found in Mexico, that eats just 2 or 3 times a year. And when the lizard eats, there is a substance that's secreted in its saliva, which sort of wakes up its intestinal cells so that the cells can now absorb the carbohydrate and the protein. It turns out that investigator spent a number of years investigating what was in this saliva, and it is very much related to GLP-1. It's got about a 50% homology, which means about 50% of the structure is the same. And where it differs, though, is where DPP-4 acts, so that it's not inactivated very quickly when it's injected. As a matter of fact, it's around for about 10 hours. So these are all the things that I just talked to you about what GLP-1 does. Turns out that this homologous substance, and the first one that was marketed was called Zenoctide, does exactly the same thing, except that it's not degraded, and therefore it has a very long action. So the advantages of this drug, this injectable drug, is that it causes weight loss, and it does not cause hypoglycemia. However, 10 to 15% of patients will get initial nausea, vomiting sometimes, usually goes away, but it is a factor. It's expensive and probably does not cause pancreatitis. It was thought it might, but the recent evidence suggests that might not be true. I think I won't even talk about pramlintide since we don't use it in the county, and it's usually only used in type 1 diabetic patients. Now, this is a new class of drugs, sodium glucose transporter 2 inhibitors. When the blood goes to the kidneys, the plasma goes into the glomerulus. This is the long tube that goes through the kidneys, coming out in the urine here. And as the plasma goes through these two tubules, there is an enzyme, SGLT2, which absorbs the glucose back into the blood. And 90% of it is done in the first part of the kidney, and the rest 10% in the second part, so that under normal situations, we don't end up with glucose in the urine. However, there's been development of drugs that will inhibit that enzyme so that people taking that drug lose a lot of glucose in their urine. And the advantage of that, and this is, I think, a very marked advantage, is that all the other drugs I've talked about required insulin secretion to work. This one does not. This works without the ability of the pancreas necessary to secrete insulin. You get some weight loss, and you get some blood pressure lowering because of it. Of course, the disadvantages are that patients have urinary frequency, and there's a small increase in the urinary tract infection rate with it. And more importantly, there is a much more marked increase in mycotic infections in females, vulvovaginitis, and in males, balanitis. And of course, in 2 of the drugs anyway, the EGFR will affect the dose. So this is a new drug coming down the pike, and I have it on some authority that maybe the county is going to be able to get to use it, and I think it'll be very, very helpful. These are the 3 drugs that are been marketed, and we've all been told that they're going to be given out free for at least 1. Don't hold your breath, because the county patients probably will not be eligible for it. And the reason is that one of the restrictions, if you have an insurance, if you're insured by a policy that is sponsored by the government, you're not going to be eligible for it. And that's most of our county patients. All right, now insulin. Insulin, of course, is a wonderful drug. It's the most effective drug. The disadvantages we all know about: you got to stick your finger 3 or 4 times a day, ideally, if you really want to use it well. It can cause hypoglycemia, weight gain, and you have to have and this is the biggest bugaboo in using it, the patient needs to have a fairly consistent lifestyle for most of the regimens we use. These are the 4 criteria that I use to judge whether a drug should be used or not, the most important of which is effectiveness, then the adverse or side effects, the ease of adherence, pills being easier than injections, and cost. The cost of diabetes drugs is quite an important factor. It doubled from $7 billion to $13 billion in the first part of this decade. It's gone up even further since then. And the diabetes drugs have been the class that has topped the list for the growth in drug spending in recent years. So, which one of all these drugs should we use? Well, let's look at the first criteria, effectiveness. This is a meta-analysis of non-insulin drugs versus a placebo. There's been a lot of studies, over 25,000 patients, a lot of combinations of drugs versus placebo, and the A1C decrease has been about the same in all of the drugs that are used. This is a meta-analysis of studies that have looked at adding a drug to patients who have failed metformin, and once again, a large number of studies, large number of patients, and all of the drugs were associated with a similar hemoglobin A1C reduction. Here is a number of studies, a little bit less number, of patients who were given the drugs to those who had failed metformin and sulfonylureas. Again, the A1C reductions are the same. And finally, the best way to test the effectiveness of a drug is do head-to-head comparisons. There have been 57 trials, over 20,000 patients, and you can see the ones that have been compared head-to-head. And all of those drugs were equally effective, except a few studies showed metformin was more effective than a DPP-4 inhibitor. So in terms of effectiveness, we don't have a clear winner. So let me turn now to what we can use in the county and what we use at Martin Luther King. We start out with metformin, like it's recommended, and our first goal is to get the fasting glucose down under 130. Now, in a patient who is not taking insulin, that's a good marker because the fasting glucose is relatively stable. And this is the relationship between fasting glucoses on day 1 and the next day, and you can see a very tight relationship. This slide shows you the same relationship within a week of each other, 1 week later. And although there's some scatter up here, clinically that's really not very important because, for instance, let's take this patient here. If you have a blood sugar of 280 or your blood sugar is 200, clinically you're going to make the same clinical decision. So you can use the fasting glucose as a marker of how effective metformin is and also for sulfonylureas. And it turns out that within 2 to 3 weeks, you're going to get the maximal effect of either starting one of those drugs or increasing the dose. So our first goal then is to get the fasting down under 130. If we can do that, we wait 3 months to see what the A1C is. If it's greater than 7, then we would add a sulfonylurea. If the fasting glucose cannot be gotten down on a maximal tolerated dose of metformin, we would add sulfonylurea, again trying to get the fasting sugar down to 130. And again, if we did, we'd wait 3 months and see where we are with the A1C. If the maximal doses of those two fail, then we would add pioglitazone, and we add a maximal dose. Well, the reason is that since it takes 3 to 4 months to see how effective that is, in 3 to 4 months we will know if it's going to work or not. If you start with 15, then go to 30, then go to 45, you've got to wait almost a year before you may decide that it's not effective. And if there's increased fluid retention, edema, then we deal with it. And we haven't had all that much trouble because we don't use the drug in anyone with a history of congestive failure or if they have edema to begin with. Now, the newest drug that has been available is exenatide. At the moment, it's restricted to endocrinology and, of course, type 2 diabetes. You have to fail all 3 of those pills to be eligible to use it. It's got to only be used with an A1C of between 8.0 and 9.5% and a big BMI over 30. If after 6 months the A1C is not under 8%, then you cannot keep using it. So we start with 5 micrograms, give it twice a day. In 1 month, it's increased to 10 BID if the patient can tolerate the nausea or the vomiting, when it usually does go away. At 3 months, we measure an A1C greater than 8% and has not decreased by at least 0.5%, then we would discontinue it and start bedtime insulin. Otherwise, we continue it. We measure the A1C at 6 months. If it's less than 8%, we continue it. If not, we discontinue it. So then we go on to bedtime NPH insulin if we fail the other medications. And the rationale for that is this. So here's a cartoon, fasting glucoses on pills. You start at around 200, postprandially you go up. If you can reduce the fasting glucose by giving bedtime basal insulin, either NPH or glargine or detamir, then often the pills will keep the postprandial sugar where it was up here. If there's not enough insulin secretion to do that, of course, then during the day you'll get a rise. And this actually works. Here's a study. This is 270 fasting on failing pills. The patient was put on bedtime NPH, brought down to about 90, and you can see the postprandial rises are about the same. The starting dose with obese patients is 16 units, lean patients 10 units, and then we go up by 4 units in the obese patient or 2 units in the lean patient each time, or 10% of the current dose, whichever is greater. If you do that, and we see, even if you see patients every 2 to 3 weeks, which is very difficult in the county, it takes you a pretty long time to get that glucose down to where you want it. Therefore, patients who are able to self-titrate, we instruct them how to do that. If the fasting glucose is over 130, then obese patients would go up by 2 units that evening, or if the lean patient would go up by 1 unit, and you keep doing that every time the fasting glucose is over 130. When you get within a week and you haven't changed your dose, then we stop doing the self-titration and just follow them as usually we do. So we try to keep bedtime insulin and control them with bedtime insulin. I should have mentioned that we don't start insulin unless the A1C is 7.5% or greater. And the reason is that the lifestyle change for a patient is considerable when you put them on insulin, and because that A1C at 7.5 or less, there's not that much increase in the microvascular complications. We wait for that. If we get the fasting glucose down to less than 130, and 3 months later the A1C is still too high, then we would intensify the insulin again with a 7.5% as our goal. And here are the potential intensified insulin regimens. The first one is split mixed, NPH and regular, or Lispro before breakfast and supper. Sometimes as you increase the NPH before supper, you get overnight hypoglycemia before you can control the fasting glucose in the morning. If that's the case, putting the NPH at bedtime almost always works. We give a bedtime snack with our patients, although there may be a little bit of weight gain with it. The risk of getting them hypoglycemic overnight turns them off considerably from using insulin, and therefore we prefer not to take that chance. And if a 250-pound patient gains 10 to 15 pounds, the CVD risk is really not that much worse than it was when they were 250, and without hypoglycemia, they're more likely to stay to insulin. And these are the basal bolus regimens with giving the NPH either at bedtime or glargine once or twice a day. So if you want to intensify insulin from bedtime insulin, and you're going to a basal bolus regimen, it's very easy. You just continue the bedtime insulin and start 2 to 4 units with a lean patient, or 4 to 6 units in an obese patient before each meal. We keep our obese patients on metformin just to control the weight gain. It's a little more difficult if they go to a self-mixed split regimen. You stop all the oral drugs again, except metformin. You take 80% of the bedtime dose and split it into 2/3 in the morning and 1/3 in the evening or before supper, and then we would add regular insulin about 2 to 4 weeks later, because most patients need a short-acting insulin as well. Even many of our patients take a lot of insulin, but the maximum amount we would give to start them with is 40 in the morning and 20 before supper. And so here is the key slide as to how you judge insulin dose changes. Each one of these insulins taken at these times, the test that reflects their action is over here, and the goal is to get at least 50% of those numbers at target, and you keep going up on that part of the insulin prescription until you arrive at that. And this is just the short-acting ones that act after the meal or before the next meal. And here, as I've just said, we adjust each dose until 50% of the appropriate preprandial or postprandial values are within target. Sometimes you have to start insulin right away. You can't do it from the basal at night, and we would start with 20 and 10 in an obese patient for a split mix, and lean would be 10 and 6. And then we'd go up, as you see on this slide, 4 units and 2 units in obese and lean, or 10%, whichever is highest. Like to get the before breakfast and before supper sugars down, be under 200 in the split mix before you start increasing the regular, because if you say you're 280 and you start increasing it and you bring down that before supper sugar, that amount of regular that you needed to get the before bedtime down would be too much, and so we like to get them all under 200 before we increase the short-acting one. Basal bolus is easy. We start with 6 to 8 units before each meal, 16 at bedtime for obese, and 10 for lean. Now, it's known that if you have a high sugar before a meal, it's going to take you extra insulin in order to bring it down. So this is what we call our correction doses. So we add this amount of the short-acting or the regular insulin or the rapid-acting insulin to whatever they are supposed to take based on these blood sugars. And the goal is to get the next preprandial sugar down between 100 and 150. And it works well as opposed to not giving this insulin. Of course, this requires that they test 3 or 4 times a day, and of course, that's a big challenge. Now, pre-mixed insulins. We don't use them at MLK as little as possible. And the reason is that you can't adjust the intermediate acting insulin and the short acting insulin separately. So a common pattern, for instance, is before bedtime you're very high, you're eating a big supper, and you're okay the next morning, and by increasing the before supper pre-mixed, you're jeopardizing or increasing the chances of getting a low blood sugar overnight before you can control the before the bedtime sugar. So you don't have much flexibility using a pre-mixed insulin. And finally, a very short digression on how to treat newly diagnosed diabetic patients who come in with very high sugars and are markedly symptomatic. They're urinating like crazy, they may have blurring of vision, they've lost weight. If they are newly diagnosed type 2s, you don't have to use insulin. I know that sounds blasphemous, but Dr. Peters and I, in 1996, published a paper showing that if you give them a max dose of sulfonylureas, almost every one of those patients can be controlled without insulin. And I've treated over 300 of these patients, and we have very, very few patients that needed insulin off the bat. You've got to make sure that they're type 2s. Minority status, which in our population is easy, obesity, and very importantly, most of these patients, almost all of them will have a strong family history of type 2 diabetes in a first-degree relative. You just start with a very high dose of sulfonylureas. If they're obese and their symptoms are better, we keep going. If they're lean and their sugars 2 weeks later, or a week later, are over 300, then we would go on to insulin. But within 2 weeks, these sugars mostly come down to way under 200 and sometimes at target. And often we have to decrease the sulfonylurea, and then we would start metformin to get them on that dose. So, what's important in achieving the ADA's glycemic goals and what's not? It's really not important what drug we use. The important thing is you've got to intensify the therapy when the present regimen the patient is on is not working. And very frankly, seeing patients every 3 to 4 months and going up a little bit with a sulfonylurea or metformin doesn't really do the job. There's no free lunch. Here's the commercial. No commercials? Okay, then just look at this, and all the algorithms are written in this book with a background for everything. Okay, so let me just show you in the last 5 minutes how effective these protocols can be. These are 2 studies that were done at Hubert Humphrey by a very good registered nurse who was trained in these protocols. And those of you who go to the afternoon session will hear Maria Castellanos talk to you about this. The first study, we randomized patients. We took one patient from in the morning and one patient in the afternoon clinic, the first patient who agreed to be in the study, and put them in our study. There were 367 of them, and their A1Cs when we randomized them was 8.9%, and Maria got them down to a mean of 7%. 25% ended up on insulin, mostly bedtime. So these were patients that had sort of mild type 2 diabetes because they were randomly selected. The second study, I put her in a family medicine clinic there, was not involved at all. And the physicians there supervised her, in quotes, and referred the patients to her. And she had 178 patients. The hemoglobin A1C at referral, you can see, was 11.1%, and she got them down to 7.2%, and 83% ended up on insulin in that cohort, mostly 2 or more injections a day. So the protocols will work if the timely and appropriate clinical decisions are made. The other parts of outcomes besides glycemia are lipids and blood pressure. And this is a summary of a number of studies that have looked at what percent of patients have achieved all 3 of the ADA targets: LDL less than 100, blood pressure less than 130 over 80, and A1Cs less than 7. And you can see that other studies have ranged from about 3% up to about 18%, and in those 178 patients, Maria was able to get almost half of them meeting all 3 of these goals. This is just to remind us, as I finish up, the relationship between the microvascular complications, the risk of those, and the A1Cs. And what we need to do is what this physician that made this these recommendations back in 2600 BC, the first Chinese medical text. In terms of the microvascular complications, unfortunately what we mostly do now is practice as inferior providers. We treat the full-blown disease, which means the patient comes in with their complications, the dialysis, kidney failure, etc., and we try to treat them. We're getting a little better to be mediocre. We treat the patient before the disease becomes evidence. They have microalbuminuria, a little bit of EGFR is decreased, their retinopathy is background retinopathy, and what we need to do is to become superior doctors and prevent these microvascular complications. So this is the link to the CDU website for those of you who want the slides, and I thank you very much.
40 minutes. Great job. Mayor, stand for questions? We have.
Excuse me. Okay, bye.
Fire away.
Let me try to give you a microphone here.
Oh, I'll repeat the question.
I was in terms of the
Ah,
So many patients, it's very hard to get them to even check their blood sugar once a day, let alone 3 to 4 times a day. So I was just wondering, in that.
well, I think the problem was the pre-mixed insulins and testing only once a day. You have the problem of testing once a day no matter what insulin regimen you're on. And we have found that most all patients can be taught to mix. It takes time in some of them, but all of them can be taught to mix. And if they're only going to test once a day, no matter what insulin regimen they're on, unless it's basal insulin, you have a big problem. No.
Other questions?
When do you recommend checking C-peptide?
When do we recommend checking C-peptide? Only if you suspect the patient may be a type 1 patient, but routinely I do not check C-peptides because the thing that you're interested in is getting the A1C down, regardless of whatever the C-peptide is. But in a lean, fairly young patient who you suspect may have type 1 diabetes, then we would do a GAD antibody and a C-peptide.
Thank you.
One more question?
Forward, back.
Over here.
Yell.
Laser. Perfect. Thank you.
Wait till he comes over there.
Hi, is 60 units of NPH at bedtime when you would decide to split the dose?
Okay, so the question is 60 units of bedtime insulin. Well, in NPH, splitting the dose doesn't work because the dose you would take in the morning would work mostly during the day. It wouldn't be really a basal insulin. I usually use 80, and the point is that and we'll get to this at the U500 insulins this afternoon, the more volume that's injected, the slower and the more difficult the absorption is. And therefore, when we get to 80, we usually split it 40 and 40. You could do 30 and 30. But again, note that the basal bolus is 4 injections, and the split mix is only 2. And so if you're going to split it, it's going to be 5 injections. And we give our patients the decision. Do they want to go split mix or they want to go basal bolus? And the majority want to go to only 2 injections, split mix.
For people who are newly diagnosed and has high blood sugar, you recommended sulfonylurea at high dose. Do you see the same effect with metformin? Or?
Well, the question is, so you have a really newly diagnosed patient, high blood sugars. You can't start out with metformin at a max dose easily because of the GI side effects. So we usually take 2 to 4 to 6 weeks to build up, and therefore it wouldn't treat that patient very quickly. So that's why we start with a max dose of sulfonylureas, and once we get them down, then we will add the metformin.
And the sulfonylurea works faster.
Oh, much faster. Yes, good point.
I want to thank Dr. Davidson again.